I'm Associate Professor Lionel Reyftmann. I'm a French-Australian gynaecologist working in Wollongong in New South Wales, Australia. The subject that I would like to discuss today is a very common gynecological problem called endometriosis. Endometriosis is a gynecological disease that can affect anybody who was assigned a female at birth, and the definition is the presence of small deposits of endometrial tissue, the tissue that covers the lining of the womb, inside the abdomen in unusual locations. There are many theories that can explain endometriosis, but the one that's the most common, it explains probably 60 or 70% of the cases of endometriosis, is the theory of reflux. It's a theory that goes back to the early 1930s and was developed by Dr. Sampson in the US. And his point was that women at the time of menstruation may have a little bit of blood coming from the period that travels backwards through the fallopian tubes inside the abdomen. We have some evidence of this, and because if we do an operation with a keyhole surgery at the time of the period, we find sometimes blood in the pelvis of women. And we know that the flux and reflux of liquid in the abdominal cavity generally is predominant on the left side. And guess what? That's where we find most of the endometriosis. There are people who have three types of endo. The first one is superficial small deposits at the surface of the peritoneum. The second one is called deep endometriosis. It's a nodule, it's palpable, it's quite thick and solid, and deep nodules can be stuck on the bowel, on the bladder, at the back of the uterus in a ligament called the uterosacral ligaments. And we have a third condition, which is the deposit of endometriosis in the ovary, where it becomes, after being bright red blood from the period, an old blood that is dark, becomes brown. And for a lot of women, they may have heard that name. We call them chocolate cyst. It's a little bit disgusting. It looks like a gooey kind of brown liquid inside the ovary. The Sampson retrograde theory doesn't explain everything. There are probably some people who have endometriosis caused by other mechanisms. One that's very interesting at the moment that we're exploring is the presence of deposits of endo in the abdominal wall if you have a cesarean section. So you get the baby out, and when you do the operation of cesarean section, there is a bit of tissue that gets grafted on the abdominal wall, and people come back after a few months saying that they have a lumpy pain in a nodule in the abdomen, and we find that they have endometriosis. There are also some theories that explain that theory that endometriosis migrates through lymph vessels or through the bloodstream. There are some other ways to explain the disease. What it does is quite difficult to apprehend. There are a lot of women who have endometriosis, but they don't have any symptoms. The estimation is that 1 woman out of 8 may actually be a sufferer of endometriosis. But we're always surprised that some people have quite diffuse endo and minimal symptoms. For other people, they may have just a little bit of endometriosis, and they have very bad period pain. They have pain in the bladder, the feeling of having constantly to urinate. Sometimes they have bad stinging pain when they pass a void. We have people having pain in their bowel, difficulties to open their bowel, excruciating pain when they open their bowel. We have some people who have pain when they have sexual intercourse during sex. And it's not just at the entrance, it's a deep pain, like a stabbing pain, particularly if it touches certain positions. With all those conditions, there are a lot of women suffering endometriosis that develop some general systemic problems. One of them, for instance, it's very difficult to explain scientifically, but they may suffer from intense fatigue. There are some people for which it impacts on their quality of life, their immune system. There is probably some degree of connection between inflammation, immunity, and endometriosis. For some women, the end of the journey is actually a life of chronic abdominal and pelvic pain that ruins their quality of life, their interactions, their intimacy with their partner, that impacts on their work life. It's something that can be very debilitating. Thank God not everybody has this kind of very complex and severe endometriosis, but that's potentially one of the issues. One of the problems is that endometriosis can affect fertility. The presence of the endometriosis irritates the inside of the abdomen, creates inflammation, and the sperms, the eggs, the embryos may have difficulties to thrive and develop, which may delay the ability to become pregnant. For some women, it's the effect of the endometriosis that acts like a glue, like an adhesive, that can block the fallopian tubes or stick the organs together that creates the infertility. And finally, for some women, it's the effect of our surgeries. When we try to repair, we try to cut adhesions, where we create more problems. A good example is that if you're not a very good surgeon, if you're not very careful, and even in the best hands, when you remove a cyst of endometriosis from the ovary, you can damage and remove some healthy eggs. The treatments are actually quite codified. There is an Australian clinical guideline that has been published 2 years ago that gives us a broader definition. It's based on scientific evidence around Europe and the nice British guidelines, and there is some strong foundation. And they suggest that, for instance, women suffering from painful periods can improve with the use of hormonal treatment like the contraceptive pill. If there is a doubt, if we don't know if the patient has endometriosis, in the past we used to do keyhole surgeries for everyone, but now we have some very powerful tools like MRI, and most importantly, a transvaginal ultrasound called a deep infiltrative endometriosis that can diagnose endometriosis with a high sensitivity and specificity. There's a lot of research, notably in Europe, about biomarkers. There are probably some tests collecting a little bit of microRNAs from the saliva that can give us an estimation if someone has endo. At the moment, it's not available commercially in Australia. So for the patients that don't suffer from pain and are trying to become pregnant, the solution is generally an operation. We do a surgery to remove the deposits of endo, clean the adhesions, clean the ovaries, and if that doesn't work, at the end of the surgery, we have given them an endometriosis fertility index, but if they are not able to conceive naturally, we offer fertility assistance with IVF. And importantly, against a commonly held belief, IVF works well in case of endometriosis and doesn't seem to decrease the success rate. There are some controversial studies about this, but for most women, a cycle of IVF, regardless of the presence of endometriosis, maintains the same level of success.